The moderator for this session is Dr. Abdul Wahid. Dr. Wahid is a fellow of American College of Cardiology and a fellow of American Society of Coronary Angiography and Interventions. He has completed cardiovascular fellowship and fellowship in interventional cardiology at the University of Cincinnati. He did an additional extra 1 year of training in heart failure, as Jackie mentioned earlier. He is presently serving Western Kentucky Heart and Lung as the Director of Interventional Cardiology and Associate Director for the Heart Failure and Cardiac Transplant Program. He is boarded not only in general and interventional cardiology, but also in heart failure and nuclear cardiology. He is a much sought after interventionalist in the community, known not just for his clinical acumen and procedural techniques, but his level-headed demeanor in the cath lab. Please welcome Dr. Abdul Wahid.
Thank you, Dr. Kazimuddin. That was very kind of you. It's a matter of great pleasure and honor for me to be sharing stage with such eminent speakers from across the US who are known very well, both nationally and internationally. Thank you all once again for coming. Our next session is going to be on interventional cardiovascular diseases. I would like to re-invite Dr. Slater, Dr. Vashisht, and Dr. Kazimuddin back to the panel for this session. Ladies and gentlemen, it's my great pleasure to introduce our guest speaker for the day, for the session rather. It is Dr. Tariq Helmi. Dr. Helmi is a cardiologist from St. Louis University, was a faculty there. He did his cardiology fellowship from UT Galveston, did an interventional cardiology fellowship from Tufts University, Boston. He then served as faculty at Emory for 5 years. From there, he moved to University of Cincinnati. He was the program director of the Interventional Cardiovascular Disease Fellowship and the director of the Cardiac Cath Lab. He now has moved from there and is the Cath Lab director at the St. Louis University lab. More than anything, I have deepest appreciation for Dr. Helmi because he's my mentor. For those who work with me in the cath lab and wondered why I did certain things a certain way and why I was so anal about certain things, like especially using a long wire to get access, it's because I was trained that way. And with time, I've realized that that is the best way to do it. But seriously, Dr. Helmi, whenever I'm in the cath lab and I hit a roadblock, I would pause and ask myself, what would Dr. Helmi do? And that would shine a light at the end of the tunnel. So then I know I'm safe. So as long as I'm in the lab, and for however years I practice in the lab, I know there is a solution for every problem, and I know I've been trained well. I'm very grateful, Dr. Helmi, that you could make it to Bowling Green. It means a lot to me. And I'm sure you're happy to see me as well with my shorter hair. Because Dr. Helmi was a great proponent of me cutting off my ponytail as a fellow. And you know, I stuck around with the ponytail until I came to Bowling Green. But now he's happy to see me because it's gone. So without any further ado, Dr. Tariq Helmi.
Thank you very much for the kind invitation. It's a pleasure to be here among friends, colleagues, and to share the podium with national figures. Congratulations to the organizers for a very successful program. I think everybody's very pleased with how this program is coming. Thank you again, Dr. Wahid, for a very emotional introduction with the light at the end of the tunnel and you know. But, and I apologize to everybody who works with Dr. Wahid in the cath lab for any idiosyncrasies that he might have picked up. But again, it's a pleasure to be here today. And I was tasked today with talking about acute coronary syndromes, sort of bread and butter of interventional cardiology. We will go over briefly some of the data on the prevalence, the pathophysiology, and the diagnosis and the management, both for acute coronary syndrome as well as ST elevation myocardial infarction. I apologize because I think I have a little bit too many slides, and I will try to go through them as quickly as possible. And hopefully we can cover some of the broader points. I'm not going to go over every detail here. But going over acute coronary syndrome, you can see the numbers. This is an old slide from 2001, but the numbers still are significant, and it is a significant health problem, and it's a major number of patients that we see in the hospital. And you've all heard about how coronary cardiovascular disease is a major and a leading cause of death, but within cardiovascular disease, coronary heart disease takes the major role in what we see in terms of morbidity and mortality. Briefly speaking about the pathophysiology, atherosclerosis is a process that is progressive throughout our life cycle. And it starts fairly early. Some of this data actually comes from the Vietnam vets, some young soldiers who died at a very young age, and at autopsy, they were found to have early evidence of atherosclerotic disease. As we grow older, this disease or this process continues, and atheromas continue to grow until at some point in our lives, some of us will have some instability in their plaques, and they will present with acute coronary syndrome. And we know now that inflammation plays a major role, and cholesterol is one of the focal points of how this process continues and progresses. As cholesterol goes into the wall of the vessel, it's oxidized, and this is very pro-inflammatory. Inflammatory cells come in and engulf it, forming foam cells, and then they deposit cholesterol in the wall of the artery. They also lead to endothelial injury, endothelial dysfunction, and at the end, you end up with an atherosclerotic plaque in the wall of the artery. This is not a very pretty picture, but not all plaques are created equal. And as you can see, there are two major categories of plaques. There's a stable plaque and there's an unstable plaque. This one has a very thick cap with a sort of smallish core. This has a very rich atherogenic core with a very thin cap. This is the one that is at risk for pro-inflammatory processes, rupture of the plaque, and acute thrombosis. Once that rupture happens, there is a dynamic equilibrium between thrombogenic process and internal thrombolysis. And depending on how these arrows go, you will end up presenting either with an acute coronary syndrome, ST elevation myocardial infarction, or transient chest pains. It's important to understand this process because if you look at the data, most of the patients who present with acute coronary syndrome or myocardial infarction, looking at the pre-existing stenoses, people who have had significant stenosis actually represent a fairly small number of the patients who present with acute myocardial infarction. Most of the patients who have acute myocardial infarction have plaques that are between 50 or less than 50 or 50 to 70% stenosis. These are the plaques that we actually look at during the angiogram and walk away and say non-obstructive coronary artery disease. What we need to know is that these plaques are pro-inflammatory, they can destabilize, and they can present with acute myocardial infarction. We'll skip over this. So the presentation is as follows. Somebody has a plaque rupture, and they come in with a picture of acute coronary syndrome. They can have an ST elevation, and at that time, it's an ST elevation myocardial infarction. You know, activate the cath lab. Everybody's running in with their hair on fire. We'll talk about this a little bit later and how the timeline and the strategy and the system is very important in this category. Non-ST elevation acute coronary syndrome, you can leak enzymes and be called an STEMI, or you can have unstable angina. But then this is sort of a spectrum or continuum of the underlying pathophysiology that we just talked about. Plaque rupture, dynamic equilibrium between thrombosis and thrombolysis. So, the big points, dealing with acute coronary syndrome patients. The key points are early diagnosis, risk stratification here plays a major role in how we deal with these patients. Initial management, we'll touch base briefly on medical therapy, and then we'll talk a little bit about invasive versus conservative strategy, whether we need to take them to the lab and do an angioplasty or just send them home with a stress test and a bunch of pills. And of course, secondary prevention, follow-up, and smoking cessation, and cardiac rehab were touched upon earlier. We're not going to go over this. It is beyond the scope of this presentation. So how do we know that patients with ACS are higher risk? You look at their age, you look at the risk factors, if they have a history of known coronary artery disease, and of course the presentation determines to a major extent whether they will or will not do well during this presentation hospitalization. Chest pain has been found to be a predictor, EKG changes, and of course biomarkers. And if you look at refractory ischemia, these patients do worse, both in terms of 30-day infarctions and overall survival up to 1 year. So people who have relentless chest pain and are not actively and expeditiously managed, they fare worse than patients who we can control chest pain. EKG changes, and you can look here at ST segment elevation depression and ST segment depression. The highest point of mortality actually goes under these two categories. So ST segment depression is a major predictor on how patients will fare during their hospitalization. And of course we know the higher the troponin, the larger the size of the myocardial infarction, and the larger the infarct size is, the worse the prognosis in terms of mortality at 42 days. So people who have higher troponins, they will die more. And this is one of the hardest endpoints that we look at. So as far as diagnosis, we'll go over some of the AHA-ACC guidelines. This document is fairly new, 2014 by Amsterdam et al. So of course, when you see somebody with appropriate history, and after your physical exam, the first thing you look at is a 12-lead EKG. And if you think that you have the appropriate diagnosis, then that is enough, and you proceed from that point on. If you think that the EKG is inconclusive, the recommendation is to do serial EKGs, especially if the presentation or the symptoms of the patient continue to change. Serial collared troponins, biomarkers are very important. This puts you in a category of myocardial infarction versus not really having a myocardial infarction. And again, it's recommended that you don't trend them for 3 or 4 days that the patient's in the hospital, but at least initially, you want to see if the patient is evolving in a myocardial infarction, and this will also determine how you manage the patient. Risk scores have been proposed as a tool, a useful tool for us to be able to better manage these patients in terms of prognostic indicators as well as active management during the hospitalization. And there's a great score, but also the TIMI risk score. And I'm not going to go through this in detail, but you can see here that it's a point system. And age, risk factors, known CAD, and aspirin use all get a point. And of course, during presentation, angina within 24 hours, biomarkers, and ST deviation. That's why it's very important to get an EKG and biomarkers, because they fall into this point system, and then you get a score. And depending on what score you get, then your potential or risk or percentage of having an event is calculated in this column, and based on this score, you can easily divide patients into higher, intermediate, or lower risks, and depending on that, you can tailor your management to these patients. So this is a busy algorithm, and I apologize, but this is chronic stable angina and non-cardiac, so we'll cancel that. This is ST elevation, so we'll talk about that later. But here is the definite ACS with no ST elevation. So if you have ST or T-wave changes, ongoing pain, positive markers, hemodynamic abnormalities, you take them into the hospital and you try to stabilize them. If not, you take them to the cath lab. If your EKG is not too bad and you have negative markers, then you can actually observe these patients. And some hospitals have chest pain units with 12-hour or 24-hour observation units where you can actually monitor EKGs, draw cellular enzymes, and depending on where you go, if everything is negative, you can risk stratify them. If you have recurrent ischemia or have positive EKG changes or markers, then they go into admit to the hospital and evaluate for acute coronary syndrome and manage accordingly. So, medications that we give to patients with acute coronary syndrome. Beta blockers have been proven to be of great benefit unless there are contraindications, including cardiogenic shock, high degree AV block, and low output state or decompensated heart failure. These are the cases where you would consider withholding beta blockers. Otherwise, beta blockers are class 1 indications for patients presenting with acute coronary syndrome. High-intensity statins, this has been discussed already before, and this is the recommendation. Actually, checking a lipid profile is a class 2A, given the statin is a class 1. So if you have somebody with documented ACS, then they have the coronary artery disease, then they qualify for high-level statin therapy. ACE inhibitors and ARBs are indicated for patients with low EF, but also there's a class 2B indication for patients with coronary or vascular disease. This actually is based on data from the HOPE trial, and it is recommended that we consider this in patients even without depressed EF. Aldosterone blockers in the setting of myocardial infarction, if you have a low EF, are recommended, and this is based on the Ephesus trial. Aspirin, everybody gets an aspirin, unless they're allergic and bad allergy, but everybody gets an aspirin. Plavix or ticagrelor are also recommended in patients who present with acute coronary syndrome. And the reason they didn't put prasugrel in there because this statement applies to patients who will be managed invasively and also non-invasively, and the prasugrel data mostly speaks to invasive strategy. But again, aspirin and P2Y12 inhibitor. A 2B3A inhibitor is considered if patients are hot, that means unstable, ongoing chest pain, EKG changes, until you get them to the lab. This is not a bad idea to consider. It is a class 2B though. And if you're gonna do this, you're probably gonna be looking at integralin or eptifibatide. Again, a busy slides, but the concept is not to look at all these data. The concept is to look at the evolution of how we got to where we are with therapies. We started with aspirin versus placebo, and we know that aspirin was better. Then we added unfractionated heparin versus aspirin only, and unfractionated heparin fared better. Low molecular weight heparin, again, was better. And with the addition of 2B3A, that did better than unfractionated heparin with aspirin without the 2B3A. So we evolved from aspirin alone to the aspirin, unfractionated heparin, low molecular weight heparin, to 2B3A. And again, every time we do this, we lower our event rate and we improve patient outcome. When it comes to anticoagulation, the options are multiple. Most of us use unfractionated heparin or enoxaparin. Enoxaparin is the one recommended for acute coronary syndrome. Bivalirudin is now an option if you're going to take these people to the cath lab. And this is data from the Acuity study and the Horizons AMI. Fondaparinux was used as an anticoagulant. But if you're going to take him to the cath lab, it is recommended that you use another anticoagulant along with it because the risk of catheter thrombosis with use of fondaparinux by itself in the cath lab. Multiple studies looking at low molecular weight heparins, and the ones that actually work are enoxaparin. So the recommendation is for enoxaparin as your choice in low molecular weight heparins in patients with acute coronary syndrome. Moving on now to the question. Does everybody who comes into the hospital with ACS, chest pain that we deem angina, do they need to go to the cath lab? And the recommendations are kind of detailed. I don't want to say complex, but you see here there's immediate invasive strategy, there's early, there's delayed, and there's ischemia-guided strategy. All these people will go to the cath lab between 2 hours and 72 hours. These people will get a stress test and plus or minus go to the cath lab or be sent home on medical therapy and follow-up. Let's start with the ischemia-guided. Who does not go to the cath lab? The low-risk score. Very low-risk patients, low-risk troponin-negative female patients, and the patient doesn't want to have it. If the patient says, well, I know I may be having chest pain, but I'm not ready for this, I got a couple of things to do and I'm not going to the cath lab today, then you really can't force them. But if you look at different categories, immediate cath lab, people with refractory angina, heart failure or worsening mitral regurgitation, hemodynamic instability, recurrent angina, and sustained VT or VF. Early invasive within 24 hours, again, troponins are rising and the patient having EKG changes. Delayed, up to 72 hours, patients with high-risk profile, renal insufficiency, diabetes mellitus, history of previous PCI or prior CABG, the likelihood of them having another lesion or a problem with a stent or a graft makes them at slightly higher risk, and the recommendation is to take them to the cath lab. Not emergently, but usually during the hospitalization. Most of the data for invasive versus conservative strategy comes from a body of literature that is now very large. Tactics STEMI 18 trial was one of the largest trials actually looking at this and one of the strongest evidence that we have where you had invasive versus conservative, and the combined endpoint was strongly statistically significant in favor of the invasive strategy versus conservative strategy. And as you can see, death was not affected, and hardly you can expect to see a mortality benefit in 30 days. But myocardial infarction, rehospitalization, and death in MI were statistically significantly better, or lower actually, in the invasive strategy versus the conservative strategy. And if you look at the body of data, you can see a lot of studies in favor of early invasive strategy versus conservative strategy. And if you look at a meta-analysis of most of these trials, looking at mortality at follow-up of 2 years, you'll see that the graph actually falls in favor of the early invasive therapy. This is actually even including the ICTUS trial, which was not a favorable trial for early invasive strategy. But again, the data is mounting, and the data is there for high-risk patients with significant benefit for early invasive strategy when they present with acute coronary syndrome. This is an older algorithm, but I still follow this, and it's very, very helpful. People who are high risk, you start your initial medical therapy, and then you look at early invasive strategy versus early conservative strategy. If they really have high-risk features, they go to the cath lab. If you decide that they're not that high risk and you decide to go conservative strategy, if they have any recurrent symptoms, they go to the cath lab. If not, you look at their EF. If their EF is low, they go to the cath lab. Only if they have a very low risk profile and a normal EF, you consider a stress test. And if the stress test is low risk, they go home. Anything but low risk, that means high risk, intermediate to low risk, they go to the cath lab, which means that the majority of these patients will benefit from having an early invasive strategy. And again, a long laundry list of who gets an early invasive strategy versus conservative. I hope the message, I got it across. I'm an invasive cardiologist. I love early invasive strategy, and the data is out there to support that claim. All right, so we've talked about ACS, non-ST elevation myocardial infarction. We talked about risk stratification, initial medical therapy, and invasive versus conservative strategy. We'll shift gears now. We'll talk about ST elevation myocardial infarction. And as we discussed, this is, again, a continuum or the end of the spectrum of underlying pathophysiology of plaque rupture, thrombosis, and acute ischemia. ST elevations, as you can see, very diagnostic on the EKG, and I know you all can read ST elevations. I put this here for a reason, that we're going to talk about how EMS now can do EKGs on-site and transfer to the ED and activate. But this is something that not only people in the hospital should be very familiar with, but also EMS as well. I'll remind you again that patients with myocardial infarctions, most of them will have non-obstructive lesions on a previous angiogram. So people who present with ST elevation myocardial infarction also fall into this category of previously not having an obstructive lesion that actually was looked at and they walked away from. STEMI patients, again, early diagnosis, very, very important. Risk stratification, not as aggressive as the non-STEMI because you know that they're having ST elevation myocardial infarction. Initial management, again, medications we're not going to talk about. Reperfusion therapy is going to be the focal point of this part of the talk. And of course, secondary prevention, again, smoking cessation, rehab, and lifestyle modification, and secondary prevention with medications. So, high-risk patients who present with ST elevation myocardial infarction are the elderly, patients with anterior myocardial infarction, patients with evidence of cardiogenic shock, hypotension, heart failure, or tachycardia, are considered to be at a significant higher risk than people who present with ST elevations without these features. So these features also work into your calculation and evaluation of a patient, although they are having an ST elevation myocardial infarction, and we'll see how this plays into your evaluation of these patients and how they fare and how they do long-term after your management. The whole focal point of ST elevation myocardial infarction is time as muscle. You need to reperfuse that myocardium as quickly as possible. And this actually, again, goes to the focal point of what the guidelines want us to do, and we'll go over this in fairly clear detail just to make sure that everybody gets that point. So lytics. Lytics were the first method of reperfusion therapy in ST elevation myocardial infarction that we had. And they worked fairly well, but you had to get to the patient fairly quickly. The longer the ST elevations or the presentation, the longer the presentation, the more organized the thrombus was and the less effective was the thrombolytic therapy. It's recommended when you get to them early, when invasive strategy is not an option, or when there is delay to invasive strategy. If the patient presents at an outlying hospital without a cath lab and there's a more than 1 hour delay between lysis and getting them to the cath lab in the closest hospital. So this is one of the timelines that was proposed, and still sort of a eyeball tests. Can I get him out there within an hour to the cath lab table, or should I lyse him? And this is one thing that you have to consider. But there were limitations. Again, it worked very well early on, but later in the presentation, only about 60 to 70% of patients actually achieved reperfusion. Some of them had recurrent angina, recurrent ST elevation, re-occlusion, and had to go for salvage PCI. So then we started looking at options. Is PCI better than thrombolytic therapy in dealing with patients with ST elevation myocardial infarction? And it turns out that multitude of trials showed that that was the case. This is a landmark trial, a meta-analysis by Keeley and Grimes, showing that there is significant benefit for PCI in terms of lysis in reducing event rates, in terms of death, death excluding shock, and reinfarction. And if you look at stroke, again, there was significant reduction of stroke in patients who went to the cath lab versus patients who got thrombolytic therapy. So now we have established, based on a lot of data, and basically this meta-analysis among others, that primary angioplasty in the setting of ST elevation myocardial infarction is a better option than thrombolytics. And everybody should strive to send their patients to the cath lab for a primary angioplasty if they're having ST elevation myocardial infarction, unless there are confounding circumstances that you can't get this done in a timely fashion. The other nice thing about angioplasty is no matter how long you wait, actually, you are successful in opening the arteries. This is a mechanical process. This is not you injecting a drug and hoping that's going to penetrate a thrombus. You go in there and Dr. Wahid sees the occlusion. If it happened a half an hour ago, then the patient is very lucky. If it's been 6 or 8 hours again, he pokes through the wire, he gets the balloon, he aspirates thrombus, and he puts a stent. The artery is open. And this is a great achievement. But this is not the end of the story. This is only one of the factors. Infarct size, as relates to door-to-balloon time, portends significantly to how patients will do. The longer your door-to-balloon time is, the longer the delay with the artery being occluded, usually the bigger your infarct size is and the worse that you will do. And we've seen this in multiple trials. This is a study by Brody looking at cutoff points in timeline, looking at door-to-balloon times. And as you can see, if you have door-to-balloon time greater than 2 hours, you do worse than these two. But if you have door-to-balloon time greater than 3 hours, then your prognosis is really bad and statistically significant numbers. DeLuca went a step further, and he looked at analysis of exactly what it means to have a delay and how that affects your mortality. And it turns out, based on their calculation, that there is an increase of 7.5% of your 1-year mortality for every 30-minute delay. You can actually time this out. So if Dr. Wahid is on the golf course and it's going to take him an hour to finish his 18 holes, that gives you a 15% increase in your mortality for your patient. So every 30 minutes, add 7.5%. Oops, sorry. So STEMI guidelines. If you look at how the guidelines have approached this, they've approached it as a system. And this was alluded to earlier by the first presenter when he said that when you talk about door-to-balloon time, you have to involve administration, you have to involve EMS, you have to involve the ED. This is not an interventional cardiologist. No matter how great you are, you're not an island. You can't do this by yourself. You're part of a system, you're part of a program. And the guidelines have addressed this whole topic in that way. So it's a regional system, and the EKG is performed by the EMS personnel at the site of first medical contact. Again, first medical contact is one of the new buzzwords in this. And then reperfusion therapy should be administered as soon as possible. Primary PCI is recommended if it can be performed timely fashion by experienced operators. Okay? And again, this goes to the point of higher volume hospitals, trained staff, have seen this before. If a patient crashes on the table, are they able to manage this or not? All this goes to the point of better outcomes. The EMS are encouraged to transport patients to a PCI-capable hospital. And this may not sit well with a lot of other hospitals outlying there who don't have cath labs. That means that the ambulances will drive by them with a chest pain patient if they think he has an ST elevation myocardial infarction. But this is basically what is recommended to make sure that the patients get the best care possible. If you end up in a non-PCI capable hospital, immediate transfer to a PCI capable hospital, again, with the target of first medical contact to device time in the other hospital, in the next hospital, of 120 minutes. Okay? So again, a lot of timelines here. First medical contact to a PCI capable hospital, 90 minutes. First medical contact to a transfer hospital, 120 minutes. Fibrinolytic therapy should be considered if you're at a non-PCI capable hospital and your transfer time exceeds 120-minute target. So if you're out 3 hours and you have an STEMI and they call you and you know that you can't fly the patient because there's a storm and you can only drive him and it's going to take 3 hours, lytic therapy is the way to go because you know that your transfer time is going to be longer than the target 120 minutes, unless there's an extreme contraindication. If you are going to give lytic therapy, it should be administered within 30 minutes of you presenting to the emergency department. Okay? So, primary PCI and STEMI, it's a class 1 indication. Within patient presents within 12 hours and you can get it done within a reasonable time frame. It's recommended even if the delay of transfer is longer, if you have contraindication to fibrinolytic therapy. If you have no other options, you have to ship the patient anyway. In patients with cardiogenic shock and severe heart failure, primary PCI is the recommended strategy for management. All right, so STEMI patients, candidate for reperfusion. And you can see here, primary PCI capable hospital, take him to the cath lab, first medical contact to balloon time, 90 minutes. These are the sort of the hard target endpoints. Initially seen at non-PCI capable hospital. If you can transfer him and get him to a balloon within 120 minutes, transfer the patient. 3 minutes, yes ma'am. And if you cannot get him within 120 minutes, then you give him thrombolysis. Thrombolytic therapy is now administered, and then you transfer the patient to a PCI capable hospital. This strategy is something that over the past few years has evolved as the preferred strategy for management of ST elevation myocardial infarction patients. This is called a pharmaco-invasive strategy, where you actually lyse the patient as you would lyse them otherwise. It's not facilitated, it's not an anticipation of anything. You lyse them and you treat them, but then you ship them over to a PCI-capable hospital, and this data is basically based on 2 large studies, the CARESS AMI and TRANSFER AMI. These are the patients who had standard treatment, and these are the patients who had routine early PCI after being transferred, and these patients fared significantly better than the patients who did not get transferred. All right, briefly, because I'm running out of time, not all MI are created equal. No matter what you do and how well you treat your patients, if they have an anterior wall myocardial infarction, they do worse than if they had a lower risk non-anterior wall, a small circumflex, small OM, or an inferior wall myocardial infarction. Again, this is the same study by Brody. We remember the worst outcomes as the delays in door to balloon time, but this does not really apply to low-risk patients. Patients with small diagonals, patients without heart failure, patients who are completely stable. It really does not pan out that this is the case. So again, risk stratification of patients with myocardial infarction helps you figure out what their prognosis is and how aggressive you're going to be about treating them. Sobering facts, not every hospital has PCI capabilities and very few patients actually make it to the time. But the point here to make is, for patients who call 911, direct care begins with first medical contact. EMS provider arrives at the bedside. EMS personnel should be accountable for obtaining a pre-hospital EKG. We're making the EMS people accountable now. This is very important. Making the diagnosis, activating the system, and deciding whether to transfer the patient to a PCI versus a non-PCI capable hospital. False positives are expected, but it's okay. If you come into the hospital at 2 o'clock in the morning 2 or 3 times a year, but you save a lot of patients in the process, that's not a bad thing to have. For patients who arrive to a non-PCI hospital, whether transferred immediately to a PCI or fibrinolytic therapy, again, depends on how long it takes you to do that. Mission Lifeline has laid this out as a system, not as an isolation for operators. Another concept that recently came about is the concept of prophylactic PCI in patients with ST elevation myocardial infarctions. If you look at the guidelines the last few years, it's a class 3 indication to intervene on a tight lesion in a non-culprit artery. There's some evolving data from the culprit study and the PRIME study that shows that preventive PCI actually fares better than if you intervene on the culprit artery only and then get out and send the patient to the floor. So this is a concept now that is evolving, and I think a lot of people are considering this as a practice-changing strategy. In conclusions, reperfusion as quickly as possible. Primary PCI is the preferred thrombolytic therapy if you can get PCI. Pharmacoinvasive strategy is the current recommendation. Patients with failed lytics should go to the PCI-capable hospital without delay. Network systems need to be established for STEMI patients. And I will remind you that this is a process that starts with the patient actually realizing that they're having a problem. How many times have you seen patients who sat there and said, I've not been feeling well for the last 3 days, and I've been tired, couldn't go to the bathroom, and he walks into the emergency room and he's got ST elevations through the anterolateral leads, but Q waves, and the EF is 20%. So recognition is very, very important. You call 911, EMS, first medical contact, EKG, transfer or fax to the emergency department, activate the system, go to hopefully a PCI-capable hospital. If not close enough, then you go to a non-PCI-capable hospital and figure out exactly what you need to do. I will stop here with this diagram to keep this sort of in focus, and I thank you for your time and your attention, and I'm happy to entertain any questions. Thank you very much.
Thank you, Dr. Helmy. That was excellent. We'll have questions after Wahid's presentation.
Thank you, Dr. Helmy. That was a very important topic in our everyday practice. Moving along, I'm going to be talking about a very important technology that we use in the cardiac cath lab as interventionalists. It's on fractional flow reserve. I have no disclosures pertinent to this talk. So fractional flow reserve, or FFR, is a very important tool that we use, or a technology that we use in the cardiac cath lab, which we use to assess hemodynamic significance of coronary stenosis. Assessing physiology of a coronary artery is very important, along with just doing angiograms of coronary arteries. We know that the diagnostic accuracy of a plain angiogram at its best, overcoming the body habitus and a lot of things, and overlap of arteries, etc., the best accuracy is around about 70%. So if you had a tool that you could use in the cardiac cath lab that would augment this accuracy up higher so that you can make the right diagnosis and treat the patient appropriately. So this is one such technology we use where the diagnostic accuracy actually catapults up to greater than 90%. So what is fractional flow reserve? This is basically involves fluid dynamics and in the coronary physiology. If you look at this cartoon at the top of the slide, this depicts a normal coronary artery where the pressure in the aorta should be equal to the pressure in the coronary artery going into the myocardial bed. But when you introduce a fixed lesion in the coronary artery, what happens is there is decrease in flow or impedance of flow through this, and there is a drop in pressure across that stenosis. And if there is a way to measure this, you could correlate it with ischemic burden. The way we do that in the cardiac cath lab is we use a wire with a pressure sensor and place it across the stenosis and induce maximal hyperemia with adenosine intravenously or intracoronally, and wait for 2 minutes and then calculate the pressure drop across this stenotic segment. And FFR is merely a fraction, is a ratio basically between pressure in the distal segment to the aortic pressure. And gives us a value. It's a ratio, it has no units. And we go by a number, and that gives us an idea of the extent of ischemia that we can associate this stenosis to. So what is so unique about FFR? FFR is so unique because it does not change with the change in blood pressure, it doesn't change with the heart rate, or doesn't change with the myocardial contractility. In a normal artery, the value is 1.0. FFR relates to the severity of anatomic stenosis to the extent of the myocardial perfusion area, which is important. And it relates to the myocardial blood flow, and it also relates to the contributions of the collateral flow distal to the stenotic segment. This is a diagram that illustrates the why and how the FFR relates to the myocardial perfusion area. So if you look at the top diagram and the one at the bottom, for a same kind or an anatomic stenosis in a larger artery versus a smaller artery with a cross-sectional area of about 4.5 millimeters in both, this supplies a larger myocardium and this supplies a smaller myocardium. And if you were just doing an angiogram, you would just label it a similar significant stenosis or insignificant based on your angiographic finding. But if you performed an FFR to be more accurate in your diagnosis, you would realize that the larger the myocardial bed, the more significant the FFR. By the way, the lower the number, the more ischemic burden it is. So this is a more significant lesion as opposed to something in a smaller branch with an FFR that is not significant. So that actually helps us go further in our treatment strategy. We can apply this further to an area of a similar area of myocardium, but now part of it is scarred. So the effective hemodynamic significance of the stenosis is dropped because the amount of myocardium effectively perfused is smaller now, and that the FFR is 0.80, which is much better than having an FFR of 0.6. Like I mentioned, FFR accounts for the contribution from collaterals distal to the stenotic segment. The poorer the collaterals, the more clinically significant the FFR. And if the collaterals are more robust, then the clinical significance of this lesion drops proportionately. So in essence, the FFR accounts for various components of coronary perfusion and the interactions between them, i.e. the epicardial stenosis, the perfusion territory, the amount of blood flow, the amount of collaterals it involves. Such a unique measurement is not available with any other modalities, including OCTs or intravascular ultrasounds, or just plain old angiography. How accurate is FFR? This was a paper published by Pills in 1996 in New England Journal of Medicine, which basically compared the fractional flow reserve to the gold standards of non-invasive therapy, the exercise stress test, thallium scan, stress echoes. Patients either had one of these or all of these tests, and they were compared with fractional flow reserve. And it was found that any patient with a fractional flow reserve value less than 0.75 had a stenosis that had ischemia that was 100% for sure, that the specificity was 100%, and the sensitivity was 88%. This was in 96, and over time there's a slew of data that has showed that even if you move the cutoff up to a 0.80, that the accuracy of this investigation is above 90%, and increasing the sensitivity up to around mid-90s. So what's the clinical relevance of this technology that we use? I want to present to you three clinical trials that are relevant to this technology. One of them is historic and very important, is from the pre-stent era. This is from 2001, published in Circulation, was a DEFER study where patients with a single vessel disease had a lesion that by angiogram needed a percutaneous transluminal coronary angioplasty or plain old balloon angioplasty. These patients were randomized each of them got FFR. If the FFR was significant, they had ischemia by definition, and they underwent PTCA. But the remaining patients, they were divided 1-to-1 with FFRs greater than 0.75. Now remember, these patients are the ones that already were labeled to have a stenosis that needed intervention. So they were randomized 1-to-1 to either get the intervention or not to get an intervention, and they were followed for 2 years. And what we found was at the end of 2 years, if you had an FFR of greater than 0.75, which is not significant, and you intervened on these patients, or you did not intervene on the patients, their outcome was similar, which was important data. And moving on to 5 years, it stayed the same. There was no statistical difference between doing an intervention or not if your FFR was greater than 0.75. We have more contemporary data echoing this fact, and two of those landmark trials are FAME trial and the FAME2 trial. And these are a group of investigators from Europe, from Belgium. The FAME1 trial or the FAME trial basically compared intervention based on FFR guidance versus just angiography guidance. And the objective of this was to basically see if there was a difference in outcomes. For the background, we just spoke that the best angiogram, even if you had the best angiogram, the accuracy of that test is about 70%, and that we probably needed something more robust to elucidate the clinical significance of this stenosis. So we used the cutoff of 0.80 in this study. Inclusion criteria included patients with multivessel disease, which means that they at least had to have 2 coronary arteries with stenosis. What did a stenosis mean? Was greater than 50% by angiography. And you, as an interventional cardiologist, you labeled this patient to be a need for an intervention. Exclusion, as usual, was left main disease, bypass surgery, acute MIs, cardiogenic shock. The primary endpoint was a composite of death, myocardial infarction, and repeat revascularization. Secondary endpoints were the components of the composite endpoints: quality of life, procedure time, amount of contrast used, and the cost. What they did was basically they screened 1,900 patients, 900 were excluded, 1,000 of them divided into getting angiography-guided PCI or getting an FFR of the lesion before you did PCI. So if the FFR was not significant or greater than 0.80, you did not intervene on this patient, and you only did stents on patients that had FFR less than 0.80. So this was, again, a drug-eluting stents. This is just to show that both groups had similar baseline characteristics. And what we found was that the outcomes were dramatically different. For the group with the FFR-guided PCI, the event rate was 13.2, as opposed to an angiographic-guided PCI, where it was 18.3, and the p-value was 0.02. What it means is that there was a 28% relative risk reduction in the composite endpoint if you performed a PCI after doing an FFR. So that was pretty good data. And most of this was driven by either cardiac death or myocardial infarction. What they also found, and was very relevant in the academic setting and the administration, was performing FFR-guided PCI was cost-effective. It was cheaper to do this, and the cost was driven in the angiography-guided PCI because we were ending up using more stents in this group. That's again data going back forward from 1 year to 2 years, and the graphs continue to separate out. There was a sub-analysis just trying to or echo the idea of how a plain old diagnostic angiogram is not very accurate. Patients with angiographic stenosis of 21 to 90%, of which 20% of these actually did not have a significant stenosis by FFR. They were not physiologically significant. This is something to be worried about if you're doing just angiogram and relying on it, and especially in moderate to severe lesions. So in summary, at 5 years, that is now, 5 years have passed, and the data suggests that doing an FFR-guided PCI is not only beneficial in reducing the MACE rate, but it also reduces the healthcare cost overall. The drawback of the FAME study, I think, is that they included stable coronary artery disease and unstable disease, acute coronary syndrome. So as a daily practitioner, it is difficult for us to extrapolate this data to our patients. So I wish they had something that separated these cohort of patients. So the next study actually did that. The FAME2 trial, same group, Bernard de Bruyn from Belgium, what they did was they compared fractional flow reserve guided PCI to optimal medical therapy. I just want to briefly talk about the background behind the study. We know that COURAGE trial came around in 2007 and stents took a beating. All newspapers were all over it. What it said was that PCIs in stable coronary arteries did not improve outcome. So whether you got a percutaneous coronary intervention or you did medical therapy in a stable coronary artery disease, your outcomes were same. But we know from FAME1 trial that if you did a percutaneous coronary intervention guided with FFR, your outcomes were better than if you just did a PCI based on angiographic findings. So the objective was to compare if there was a difference between doing FFR-guided PCI and medical therapy or just doing medical therapy alone. Inclusion criteria was stable angina, atypical chest pains with documented ischemia, 1, 2, or 3 vessel disease. Exclusion criteria, prior CABG, LV dysfunction, left main disease. And the endpoints were a composite of death, MI, and urgent revascularization. What they did was they randomized about 1,200 patients in the study, and everybody and every lesion got FFR. So anybody with an FFR of greater than 0.80 did not get an intervention. They entered a registry. Half of them were followed up for further analysis. Of the remaining patients, 888 who had a significant FFR hemodynamically, were randomized 1-to-1, either to get a PCI or to get with medical therapy versus medical therapy alone. And they followed up for 1 month, 6 months, 1, 2, 3, 4, and 5 years. And halfway through this trial, the Data Safety and Monitoring Board stopped this trial. The reason was that there was a dramatic difference between outcomes in these two groups. What they found was that if you got medical therapy alone, your event rate was 12.7%. And if you got a percutaneous intervention based on FFR, and if you got an intervention along with medical therapy, your event rate was 4.3, and this was dramatically different from medical therapy alone. So this is something different and new from the COURAGE concept. Most of those were driven by urgent revascularization. So this medical therapy patients needed more interventions, and most of them were driven by acute coronary syndrome. So this medical therapy patients had a significant FFR. You put them on medical therapy. They ended up with badness. They ended up with heart attacks. They needed stents. So in conclusion, what happened was we found that the FFR-guided PCI improved outcomes as compared to medical therapy alone. And this was driven, of course, I said that, by urgent revascularization. And in patients with functionally non-significant stenosis, the one that I entered the registry, medical therapy alone resulted in an excellent outcome. So if you had a patient in your lab and you did an FFR, it was greater than 0.80, you could send the patient home on medical therapy and the patient will do well, no matter what the angiogram showed. So what are some clinical applications of this technology? We use this technology to evaluate multi-vessel disease in treating complex diseases, coronary diseases, assessing tandem lesions, and also to assess prognosis of results from DES stent placements. That's drug-eluting stent placements. Here is an example of a gentleman, 67 years old, with stable angina with positive stress test. This is the right coronary artery. This is the left coronary artery. And if you're an interventionalist in the lab and you see this, that's a pretty scary lesion, and you'll have to strategize it because it's a trifurcation lesion, and you want to make sure you're doing the right thing for the patient. So probably he is a candidate for bypass surgery. But let's do FFR and see what happens, because it's an FFR talk. So what we found was that the fractional flow reserve of the right coronary system, which compared to this looked more moderate to severe, the FFR was significant and 0.41. And the FFR of LAD was 0.94, the left anterior descending artery. The diagonal branches were 0.89 and 0.90, which were all not significant hemodynamically. So the patient received a stent. We did a post-stent PCI. FFR was 0.80, which I'll talk to you again. A value greater than 0.96 is the best result. Anything lower means it's not an optimal result. So you can do a pullback of the wire with a sensor in it. As you pull it back, we found that there was a shift in gradient, and we figured out that this is the area where the recovery happened, and that there might be a lesion in here. So we fixed that with another stent, and a repeat FFR of this lesion was 0.94. So instead of the patient getting bypassed for the assumed 3-vessel disease, the patient probably just got 2 stents in his right coronary artery, and with good medical therapy, and this patient will have a good clinical outcome based on all the data we have. We know that FFR is also used to evaluate tandem lesions. So in cases like this, you can actually place your wire beyond the distal stenosis at maximal hyperemia, and you can pull the wire back and see where the gradient closes. So this is the distal segment that shows the extent of FFR, which is a rather generous shift as opposed to the proximal segment. Hence, this segment was significant, and the patient just required intervention at the distal segment, not requiring intervention in the proximal segment. This is an example where if you have diffuse disease, like in patients with diabetes or in patients with transplant arteriosclerosis, or in transplant rejection, where you have diffused disease, if you do a pullback on these, you will see a gradual decrease in the gradient. And these patients would probably do well with bypass surgery rather than needing a percutaneous intervention. Here's another example where we can be fooled with 3-vessel disease, a patient with class 3 angina. You did a stress test. Stress test shows normal perfusion with no defects. The problem with this is that there is balanced ischemia, and that the perfusion reads it as a normal scan. But in essence, when you did an angiogram, the patient had stenosis in the right, the circumflex, and the LAD territory. Did an FFR of these, and all the 3 of them were significant hemodynamically, and the patient needed bypass surgery. So FFR is also something that we use to know the prognosis or the outcome of post-intervention. So the post-stent FFR, the higher the number, the lower the event rate. So if you want to know if your stent procedure was appropriate and successful, you want to make sure your FFR is closer to 1.0. So what do the guidelines show? The European guidelines are more welcoming of this technology, and they've given this a 1A indication for any stenosis in the left main greater than 50%, anything in the proximal LAD needing intervention, any triple vessel disease with LV dysfunction needing intervention, class 1A indication for in the European guidelines. In the US, it's 2E. It's a 2A indication for FFR. It's reasonable to use it in the assessment of intermediate coronary stenosis, i.e. 30 to 70% by angiography in patients with anginal symptoms. And if you have equivocal stress test or an absent, or you didn't have a non-invasive stress test, it is warranted. It can be used in this scenario. So in summary, we know that FFR is a very important technology that we use. It actually augments your diagnostic accuracy from a 70% to upwards of 90% if you used it. And it's a tool that we use to assess the coronary stenosis, and it actually collaborates with the ischemic potential. FFR-guided PCI improves mortality and morbidity, and it's also shown that FFR-guided PCI decreases overall cost of healthcare. Thank you very much.
Thank you, Dr. Waheed. Excellent talk. I have a question for our panelists. I would like to know what percentage of patients in your practice we are doing FFR. This is to Dr. Vashist from University of Connecticut.
We do a fair number of FFR. It also depends on the patient population in terms of what kind of workup has been done prior to them coming to the cath lab. If we do have a really a high-risk stress test and symptoms that go along with the territory, then we might skip the FFR. But on the other hand, if there is an ambiguity about the stress test or the symptomatology for atypical chest pain, an intermediate lesion or indeterminate lesion, then we have a low threshold to doing FFR on those patients. I think the point that Dr. Waheed made was a good one about usually the dictum is that when you don't want to intervene on a lesion, you do an FFR. But paradoxically, it actually increases it because when you have a triple vessel disease in somebody who's diabetic, like the case that you just pointed out, one of the things that has panned out in all the trials is that it actually reduces the burden technically from angiographic triple vessel disease to a functional one vessel disease, which can be dealt with percutaneously. I think the other application for it is now the functional syntax score, where we use the syntax score to divide if patients should go for a bypass or angioplasty. But with a functional syntax score, you do an FFR of all the lesions, and then you do a syntax score of only the ones that are functionally significant. And that seems to discriminate better in terms of both the outcomes and planning. So I think it's definitely an important tool, and we actually use it very liberally. There are newer technologies that are coming out for FFR. Most of the problems with some interventionalists to adopting FFR has been the kind of wires that we have. They're not the most friendly wires. People have their own workhorse wires. And now there are products that are coming out and are available in the US where you can have catheter-based FFR, which can be used over your favorite wire. And I think the adoption is going to be more widespread. And I think definitely the cost savings and the outcomes that you've already alluded to. So in our practice, we have a very low threshold for using the FFR.
Yeah. Definitely, I agree with you. I don't think we should be doing unnecessary FFRs as well. So you got to be careful because sometimes we can create dissections simply. So angiographically, you need to assess the lesion. I understand the limitations of angiography, but again, it's a great tool.
I totally agree that FFR is not without its problems because the wires, as I said, are not very friendly. There are definitely folks that can have ill effects with it, and that's the reason why I prefaced my comment by saying where there's an ambiguity in terms of symptoms and the stress test. Remember, the first paper by Peels was actually the gold standard was thallium, and part of the reason why thallium worked was because it was a Dutch study. There were patients were number of were diabetic and obese, and there were other challenges that we see in nuclear world were not applicable to those patients. So I think while they mirror each other, there are subtle differences in what a stress test does and what an FFR does. While the FFR is mostly for epicardial disease and doesn't account for downstream microvascular disease, as Jacqueline pointed out, that women might have, which a stress test might pick up because that serves a different purpose of relative flow reserve. So there are minute differences between those two. But I absolutely agree that if you have ischemia that is positive in a patient who has chest pain and the same vessel has a lesion, then unless there are reasons to doubt all these pieces of information, there really is no need to do an FFR on that. So
yeah,
that point's well taken.
That's very important.
For the panel about FFR in a patient who comes into the classic chest pain, has a real troponin elevation, take him to the lab, and at best you see a moderate lesion, and you don't feel like stenting a moderate lesion. So has that been studied in patients who actually have a non-ST elevation MI and the role of FFR?
To my knowledge, apart from what Dr. Waheed just said about the FAME1, where there was a mixed bag, the other ones actually had more stable patients. And I think if you're really concerned about a lesion with non-ST elevation MIs and you really think that that lesion is probably that you're worried about, I would probably IVUS it. But I personally don't know of solid data for a mild lesion and also with non-ST elevation MI. But I think to extrapolate it, it probably would be a favorable prognosis if you got an FFR of 0.9. I have to say, and I have to admit that we oftentimes get fooled both ways. You know, you see a tight lesion and the FFR is not significant, and vice versa. I don't know if you have any comments.
Just to sort of come back to what Jacqueline talked about before, we see this not uncommonly in women. They come in and they've made troponins and they've had a chest pain syndrome, and then we take them to the lab and they don't have very much. Maybe some luminal irregularities, maybe a 20% stenosis, something like that. What do you do about that? We've started to do, and we've published some things about this, but we're doing a study right now where we're doing OCT in these patients. And what we're finding is not uncommonly that you find that you have a fissured plaque or an eroded plaque, not so much of a ruptured plaque, but just, an area, of plaque that's kind of, hollowed out a little bit away. And we have not gone on subsequently to stent those if they're not obstructive, but we feel we get a good explanation for why this patient presented that way, and then with the standard preventative therapies like statins and antiplatelet agents, et cetera, you can probably manage most of these patients medically. But there are alternate approaches to try to understand this, and I think that the whole syndrome of unstable angina, it becomes a very complicated syndrome when you start adding in all these different types of patients. But in our lab itself, we use FFR a lot. It can be extremely valuable, but it's mostly for the intermediate lesion where you're just not sure if it's obstructive or not.
And I think one of the things is that we are become so fixated with all the DOTA balloon time and everything else that we have our first thought process is always to rule out this as a coronary-based event, and so we get fixated on, well, there's a troponin, there's a chest pain, and the shortness of breath, and the lesion's mild, but there are other processes that need to be entertained as well, myocarditis and pericarditis. So I think in the right patient setting, yes, you would go to the next step, but I would probably, if there's only mild luminal irregularities, that's not uncommon either.
This question is for Dr. Helmy. We would like to we would ask you to comment on FFR and IVUS as a strategy and superiority of FFR in evaluating an intermediate lesion.
So there's this old saying in the cath lab, if you want to stent a lesion, you do an IVUS. If you don't want to stent a lesion, you do an FFR. And I think this was sort of alluded to earlier. They look at different things. So the FFR, as mentioned by the Dr. Wahid's presentation, looks at the physiology, looks at the level of limitation of flow to the downstream myocardium. IVUS and OCT look at the anatomy of the lesion and how tight it is. There have been several studies that correlated abnormal FFR with the minimal luminal area, and multiple numbers are floating out there. 4 millimeters square for proximal LAD and proximal vessels, down to 2.6, 2.7. It's all over the place. The bottom line is that if you have a suspicion of a hemodynamic significance of a lesion, I think FFR is the tool for you to choose. Back to the point where, is it valid in acute coronary syndrome? There's early data by LISAR because of the endothelial dysfunction in the setting of acute coronary syndrome or non-STEMI, that sometimes we worry about not achieving maximal hyperemia and not getting the actual true FFR. And the proposed timeline was the first 2 to 3 days after a non-STEMI, FFR is not valid. There is a more recent trial, though, that came out suggesting that we probably can use FFR in this setting. I apologize, I'm blanking on the name of the study, but I will pull it up for you. I think where I have questions about hemodynamic significance, I use FFR. If I have questions about reference vessel size, length of the lesion, optimal deployment or malapposition of a stent, I call on my OCT and my IVUS.
Now a quick question again. If you have a patient with acute coronary syndrome and a ruptured plaque and troponins are really positive, and you did an angiogram and you found an intermediate lesion which is ruptured plaque, would you stent that lesion or would you treat medically?
That's a very tough question that we always face. For the intermediate lesion, if you're left with a 50% stenosis and it's a ruptured plaque and it caused this kind of syndrome, I stent that. What I don't stent sometimes is somebody comes in and it looks like an STEMI, and and then you, for some reason or another, you find there's just an enormous thrombus burden, and then you give a 2B3A blocker to try to relieve that, and all of a sudden it all goes away. And you look at this person, and they don't seem to have any lesion whatsoever, but yet you knew that this, something had happened there. It just wasn't a very big plaque that ruptured, but it caused a big thrombotic event. Those patients I leave alone. If I really can just clean them up pharmacologically, I don't stent them.
So what happens if it's a STEMI and you do a thrombectomy and you're left with a 40% stenosis?
Those patients I'll usually stent, but sometimes I'm left with almost nothing, and those I leave them alone.
But that's the example of the plaque erosion that you just mentioned, where OCT has been done in the subset of these patients, and the proposed study/strategy is the erosion, leave them alone, rupture and thrombosis, stent them.
Yeah, I think though that when you see that 40–50% lesion, I think you're dealing with a combination of erosion and thrombosis.
Right.
And when we're looking at these women with minor luminal irregularities who've made troponins, we don't see any thrombus. We just see the little bit of erosion in the plaque itself.
And especially in presence of potent antiplatelet therapy now, I think we can leave the moderate lesions, not stenting, and treating them aggressively with dual antiplatelet therapy and statins. Thank you, everyone.
Thanks a lot.